I begin the examination with a general inspection of the patient. I note to see if the patient is sitting comfortably or is in any acute distress, and I look at their overall comfort level. I note any specific discomfort cues that might indicate renal or biliary colic, perforation, peritonitis, or a shock-like state caused by pancreatitis. I assess the neck region, palpating for any Virchow's node in the left supraclavicular region. Next, I ask the patient to bring their thumbs together, observing their angle, where an angle between the nail bed should be around 160 degrees. I then look for whitening of the nails due to hypoalbuminemia. I examine the eyes and mucosal membranes, looking for any pallor that could indicate anemia or yellowing of the skin and eyes that could indicate jaundice. I also assess skin discoloration of the palms and of the soles of the feet. I test for other symptoms such as a musty or sweet odor of breath due to ammonia and liver failure or a body odor. I then check for resting tremor by having the patient stick their hands out, followed by flapping tremor. Once this is done, I check for pitting edema in the patient by holding down on the anterior component of the tibia for 5 seconds. This could also be done in the medial malleolus or the dorsum of the foot. I then ask the patient to lay down as we are going to be moving on to the next component of the examination. With the patient in the supine position, I'm looking at the contour of the abdomen, which appears concave and flat. I assess the skin of the abdomen, looking for any scars, bruises, lesions, silver striae, or purple striae, which could indicate Cushing syndrome. I'm also looking for any engorged periumbilical veins. Once this is done, I assess all quadrants, looking for any visual masses. I will then have the patient cough and check for any herniations in the inguinal region. I will start off by warming up the stethoscope for the patient's comfort. I start by placing my stethoscope on the right lower quadrant, listening to the iliac region. This is where I may hear bowel sounds or peristaltic activity of the bowel movements. The sounds will be heard over a minute in one area, and I can normally hear anywhere between 5 to 34 bowel sounds per minute. I will be assessing the noise quality of the sounds, such as clicking or gurgling, and that should be heard every 5 to 10 seconds. If there were no sounds present, this could be indicative of paralytic ileus, and if the peristaltic activity is increased, high-pitched bowel sounds would be heard. I will now be listening for bruits over the aorta, which is located around 2 inches above the umbilicus. Normally you would hear bowel sounds here, but if I were to hear a bruit in both systolic and diastolic phases, this could be a suspicion for abdominal aortic aneurysm. I will now listen over the right renal artery, which is away from the aorta. I will do the same on the left renal artery. If a bruit is heard in both, it is suggestive of renal artery stenosis. I will also listen for any bruits over the iliac arteries on both the left and the right side. I will then check the femoral arteries on both the left and right side as well. I will now be listening for a peritoneal friction rub by placing the stethoscope on the right upper quadrant and auscultating for a grating sound with respiratory movement. If heard, this would indicate liver tumor or a gonococcal infection. I will now be moving on to conduct the venous hum, placing my stethoscope on the epigastric area. Here I am paying attention to soft humming noises that occur during both systolic and diastolic component. These could indicate increased collateral circulation, which is seen in hepatic cirrhosis. I now move on to check the succussion splash. Here I place my stethoscope on the right quadrant under my hand, and then I shake the other abdomen side to side, listening for any sloshing sound that would indicate gastric outlet obstruction. I will now be moving on to percussion, beginning in the right lower quadrant and moving in a clockwise direction. It will be noted that I am looking for tympanic notes throughout the abdomen in all 4 quadrants with scattered areas of dullness. In the right lower quadrant, we hear tympanic due to air that fills the intestines. Moving on to the right upper quadrant, we hear dull notes due to the liver. In the left upper quadrant, it should be tympanic again due to the stomach bubble, and then the left lower quadrant is tympanic as well. If you were to hear opposite sounds, that could indicate situs inversus, and then a large area of dullness could also be due to an underlying organ or mass. Moving on to palpation, specifically light palpation, I will be using my hand in all 4 quadrants and using my other hand on the patient's shoulder to keep them steady. Using one hand, I gently palpate with my palmar surface using the finger pads and keeping the hand horizontally parallel to the abdomen. I will have the patient bend their knees, and then here I'm just looking for tenderness, masses, or if a patient is in any pain. The abdomen should feel soft in consistency. If instead there was any muscle resistance or rigidity, it's key to assess whether it's voluntary versus involuntary muscle resistance. I'm also asking the patient to breathe with an open mouth, and I'm trying to palpate during exhalation, which should help relax muscles while keeping arms on their side. Next is deep palpation, where I will be placing my left hand over my right, using this to place pressure on my right hand. Again, I'm repeating this in all 4 quadrants. I'm trying to identify any masses or enlarged organs as well as characterize that said mass. I then ask the patient to cough to assess for any pain. I will now be testing for rebound tenderness. Here I'll be pressing down and releasing my hand back up quickly, and I ask the patient to let me know if they feel any pain. If there was pain, this rebound tenderness would present as a positive Bloomberg sign. I will now assess for referred tenderness by pressing on the left lower quadrant with my fingers firmly and slowly. The pain would present on the right lower quadrant, and if that pain was present, it would be a positive Robsing sign as seen in appendicitis. I will now begin percussion of the liver, where I begin at the jugular notch, moving down 5 centimeters to the bony prominence, and laterally at the second rib, counting down until the resonant turns dull. I will then mark this with a marker. Then starting from the bottom of the abdomen, just below the area of the umbilicus, I will percuss upwards, noting the notes as they turn from tympanic to dull note. The normal liver is between 6 and 12 centimeters. I would then measure this to make sure that it is within that. A pleural effusion or pneumonia would give a false increased value, where chronic gas would give a false lower reading. Hepatomegaly would lead to an increased liver size. Next, moving on to liver palpation, I place my hand under the patient's back and lift the patient up around the 11th and 12th rib, placing my right hand on the right abdomen lateral to the rectus muscle, below the patient's right costal margin. I then ask the patient to take a deep breath in. Here I'm feeling for the edge of the liver against my finger pads. Normally the liver is a smooth surface with soft consistency with a definitive edge and regular margins. If there was tender hepatomegaly, this could indicate right heart failure or hepatitis. To percuss the spleen, I will again begin counting ribs down from the jugular notch, 5 centimeters to the sternal angle, and then laterally to the left from the second rib. I will then count down until the 6th rib to be able to assess the spleen. The boundaries are superiorly bounded by the 6th rib, laterally bounded by the left anterior axillary line, and inferiorly is the left costal margin. Here I am looking for a tympanic note. A dull note would indicate splenomegaly. I will now attempt to palpate the spleen. To do this, I start by supporting and lifting the left rib cage with my left hand. I ask the patient to take a deep breath. I will then keep pressing the rib cage forward and try to feel the spleen by palpating in circular motion from the right lower quadrant and moving to the left costal margin. Normally, the spleen is not palpable unless it is enlarged, which would indicate splenomegaly. If there was enlargement, it would be palpable 2 centimeters below the left costal margin. I will now palpate the kidney. Normally I would palpate both kidneys, but for the purpose of the examination, I'm only going to be palpating the right. Here I will place my left hand on the back below the right 12th rib. I will then lift my hand upward and ask the patient to take a deep breath and hold. I palpate deeply with my right hand in the right upper quadrant and try to capture the kidney between both of my hands. I will then ask the patient to breathe out and stop. Again, here I am noting for size, shape, contour, and any tenderness. With the patient lying down, I will move right into examining for aortic pulsation. To do so, I will place my hand slightly to the left of the midline and feel for pulsation. If the patient is over 50, I would measure the width of the aorta. A width greater than 2.5 raises suspicion for abdominal aortic aneurysm. Next, I'm going to check for ascites in this patient. I will be assessing any shifting dullness to determine the border between tympany and dullness in the abdomen. I start percussing in the areas of tympany clockwise, and then I will map out the borders. I will identify the point where the tympanic note changes to dullness. Usually dullness shifts to the bottom and the tympanic to the top. I will now be assessing for Murphy sign. Here I will palpate the gallbladder area medial to the midclavicular line while the patient is lying supine. I will ask the patient to inhale deeply, which expands the lungs and pushes the gallbladder against my fingertips. The Murphy sign is considered positive if they can't do this and stop their inspiration because of pain. Finally, I will assess for costovertebral angle tenderness. I will first ask the patient to sit upright, and then I will count their vertebrae down until I reach the 12th rib. I will then place my left hand between the lower part of the 12th rib and the transverse process. With my right hand, I will use the ulnar surface to strike on the back. If tenderness is present, it could suggest pyelonephritis.